The next topic in Rheumatology Rapid Revision series is Spondyloarthritis. Spondyloarthritis, written in short as SPA, is a family of diseases which include Ankylosing spondylitis, reactive arthritis, psoriatic arthritis, enteropathic arthritis, juvenile onset arthritis, and undifferentiated arthritis. In recent times, the disease spondyloarthritis as a group has also been subclassified into axial spondyloarthritis, which involve spine, thoracic cage, and pelvis, and the other subtype is peripheral spondyloarthritis, and these affect peripheral joints, that is the joints of extremities. Let's look at the first among them, that is ankylosing spondylitis. This is a chronic, progressive, and inflammatory disease of axial skeleton, and the hallmark of the disease is bilateral sacroiliitis. Peripheral joints and extra-articular structures are also sometimes involved, and it is present more commonly in men than in women, and usual age of presentation is second to third decade of life. These patients show strong association with HLA B27. The clinical features of ankylosing spondylitis include back pain and stiffness, extra-axial arthritis, chest pain, juxta-articular pain, extra-articular findings, constitutional symptoms, and neurologic manifestations. Back pain and stiffness is typically more in morning and reduces with activity, and it does not decrease with rest. Extraaxial involvement can be shoulder and hip joints, which are seen in 25 to 30% of the patients, and another 30% of the patients may have other joints which are extraaxial that are involved. Chest pain can be due to thoracic involvement and involvement of muscle insertions in the rib cage. Juxta-articular pain can be due to enthesitis, which is the inflammation of the location at which ligament and tendons are inserted. Common sites of involvement include greater trochanter, iliac crest, ischial tuberosities, tibial tubercles, and heels. Extra-articular manifestations can be anterior uveitis in the eye, which can be seen in up to 40% of the patients, aortitis, aortic insufficiency, GI inflammation, cardiac conduction defects, amyloidosis, and bilateral pulmonary upper lobe fibrosis. Constitutional symptoms of fever, fatigue, and weight loss can be noted. Neurological features are usually related to spinal cord involvement, and there can be pathological fractures of spine. Examples include atlantoaxial subluxation and cauda equina syndrome. in the approach of ankylosing spondylitis. History plays an important role, and physical examination may reveal joint tenderness, reduced chest expansion. Schauber's test, which measures the lumbar spine flexion, may show a decrease in spine flexibility. In laboratory evaluation, there can be elevated ESR and CRP. There can be mild anemia. RA factor and ANA will be classically negative in these patients. In patients who have negative radiological findings, they can be subjected to HLA-B27 testing, and if it is positive, it helps in the diagnosis of ankylosing spondylitis. In the radiologic examination, there can be a normal X-ray in early stages of the disease, but as the disease progresses, the sacroiliac joints may show bony erosions that are usually symmetrical, and it may lead to fibrosis and finally ankylosis. Spine shows squaring of vertebra, syndesmophytes, annulus, fibrosis, ossification, and ossification of the longitudinal spinal ligament causing bamboo spine. Enthesitis can also lead to calcification and may be seen as opacities on X-ray. In patients with negative X-ray and early stages of the disease, MRI of the spine can be performed, which may show early intra-articular inflammation, cartilage changes, and bone marrow edema. The differential diagnosis for ankylosing spondylitis include osteoarthritis, degenerative disc disease, muscular strain, fibromyalgia, metabolic, infectious, or malignant causes of back pain, diffuse idiopathic, skeletal hyperostosis can also form a differential. Now let's look at the treatment of ankylosing spondylitis. Exercise is of utmost importance to maintain joint mobility and flexibility. NSAIDs are first-line pharmacological treatment and they provide good relief from symptoms. TNF modulators including etanercept, adalimumab, infliximab, certolizumab, and golimumab are found to improve disease function and reduce bone marrow edema on MRI, and they are generally used in patients with treatment failure after at least 2 NSAID trials. An IL-17A antagonist, secukinumab, has shown to reduce signs of disease activity in cases of peripheral arthritis. Sulfasalazine of 2 to 3 grams daily is shown to improve outcomes. Glucocorticoids are not shown to be beneficial. Intra-articular or intralesional steroids used in cases of severe disease. Uveitis is managed with topical glucocorticoids, or sometimes systemic steroids can be used. Corrective surgeries is used in serious cases. The next type of arthritis within spondyloarthritis is reactive arthritis. This is an acute, non-purulent arthritis that occurs in response to an infection that happens elsewhere. Classically seen in patients following GI infections and urogenital infections. Some bacteria are identified as being definitive triggers, and these include enteric organisms such as Shigella, Salmonella, Yersinia, Campylobacter species, urogenital organisms including E. coli, Chlamydia, and even Clostridium difficile infection. Let's now look at some of the important clinical features of reactive arthritis. The average age of presentation is usually from 18 to 40 years. In patients with enteric infection, we see a 1:1 male to female incidence ratio, whereas urogenital infections are predominantly seen in young males. In most of the cases, history of urogenital or enteric infections are seen 1 to 4 weeks prior to the onset of arthritis. Other symptoms include constitutional, such as fatigue, fever, malaise, weight loss. The arthritis is classically acute, symmetrical, oligoarticular, and predominantly involves the lower limb with sacroiliitis. Other inflammations include enthesitis, dactylitis, which is also called as sausage finger. There can also be plantar fasciitis and Achilles tendinitis. Ocular features include uveitis, conjunctivitis, keratitis, and rarely even optic neuritis can occur. Other features include urethritis, where urethral discharge may be intermittent, and patients can also be asymptomatic. Other urogenital manifestations include salpingitis, cervicitis, prostatitis. Patients can have mucocutaneous lesions including painless ulcers on glands of penis called circinate balanitis, cutaneous vesicles on palms and soles called keratoderma bleneragica. Other features can include pleuropericarditis, aortic regurgitation, secondary amyloidosis, and neurologic symptoms. In evaluation of reactive arthritis, patient can be assessed for previous or ongoing infections through serologies, cultures, or molecular diagnostic methods. Patients will have a classical rheumatoid factor and ANA negativity. Other features include mild anemia with a leukocytosis, and patients can have elevated erythrocyte sedimentation rate. HLA-B27 is positive in up to approximately 50% of the cases, and it may be useful in diagnosing in patients with atypical presentations. HIV screening should be performed in all patients because reactive arthritis is one of the initial symptoms of HIV. In cases with hot swollen joint fluid or synovial fluid analysis needs to be done to rule out crystal arthropathies and to rule out infections. Radiographs can show enthesitis with calcification. Patients can also show bone erosions and sacroiliitis. There can be new periosteal bone formation. Let's now look at the treatment of reactive arthritis. Although reactive arthritis is caused by an infection, the role of antibiotics is not proven in these cases. However, in cases with acute chlamydial urethritis, treating with antibiotics reduces the progression to reactive arthritis. In patients with no contraindications, NSAIDs can be used for symptomatic relief. In patients with persistent arthritis, sulfasalazine up to 3 gram in divided doses can be used. Immunosuppressive therapy including azathioprine or methotrexate can be used in patients with debilitating disease that is refractory to other treatment options. However, this is contraindicated in cases with HIV infection. In severe chronic cases, anti-tumor necrosis factor alpha agents can be tried. Patients with uveitis should be referred to ophthalmologist and should be treated aggressively to prevent progression. When it comes to the outcome of reactive arthritis, symptoms can persist in patients for up to 3 to 5 months, whereas in up to approximately 15% of the patients, the symptoms have chronic phase as well. Okay, so the next topic in seronegative spondyloarthritis is psoriatic arthritis. This is a chronic inflammatory arthritis that affects approximately up to 30% of patients with psoriasis history. In patients with axial disease of psoriatic arthritis, approximately 50 to 70% of the patients show HLA B27 positivity, whereas in patients with peripheral joint involvement, approximately less than 20% of the patients show HLA B27 positivity. In psoriatic arthritis, approximately 80% of the patients have a preceding psoriatic skin lesion, whereas approximately 15 to 20% of the patients develop arthritis first and then followed by a psoriatic skin lesion. Other common associated features of psoriatic arthritis include nail changes that are associated with psoriasis, including nail pitting. Patients also have a classical dactylitis, that is swelling of finger, and patients can also have enthesitis. Let's now look at the patterns of joint involvement in cases of psoriatic arthritis. There are 5 distinguished patterns of psoriatic arthritis, and there is a lot of overlap seen. Among them, the first pattern is asymmetric oligoarthritis. Second is symmetric polyarthritis. A third, predominant distal interphalangeal joint involvement. A fourth, that is arthritis mutilans. And a fifth, spondylitis with or without sacroiliitis. Asymmetric oligoarthritis is usually known to involve proximal interphalangeal joint or distal interphalangeal joints, small joints of lower limb. It can also involve knee, ankles, and even wrists. Symmetric polyarthritis, contributing to approximately 40% of all the cases of psoriatic arthritis, usually mimics rheumatoid arthritis, but the distinguishing features here are absence of rheumatoid nodules, presence of a preceding psoriasis or psoriatic skin lesion, and classical absence of rheumatoid factor. Predominant DIP joint involvement contributes to 15% of the cases of psoriatic arthritis, where there is isolated distal interphalangeal joint involvement, and these patients are classically associated with presence of nail changes seen in psoriasis. Arthritis mutilans is relatively rarer disease, with approximately 3 to 5% of psoriatic cases being arthritis mutilans. However, this is an aggressive, destructive form of disease with severe bone deformities, and patients can also come with dislocations. Spondylitis or sacroiliitis usually presents with axial skeleton involvement. Sometimes the patients can also have a peripheral joint involvement as well. Approximately 20 to 40% of the patients with psoriatic arthritis show an axial involvement. Now, how do we evaluate for psoriatic arthritis? One of the most important classical feature of psoriatic arthritis is presence of psoriasis, which becomes a very significant past history for the patient. Along with this, a thorough physical examination of the patient needs to be done to look for any psoriatic skin lesions which are probably missed or go unnoticed by the patient. This is usually seen in upper back or gluteal cleft, which are commonly missed during observation. Apart from this, the patient is also negative for rheumatoid factor. Patient can have anemia, an elevated ESR, and an elevated C-reactive protein, which are both indicators of ongoing inflammation in the patient. In patients with fulminant disease, HIV needs to be ruled out. Patients with inflammatory picture in synovial fluid or inconclusive biopsies can have psoriatic arthritis. So there needs to be a high degree of suspicion in such patients. Radiographic changes in patients with psoriatic arthritis include joint erosions, bony ankylosis, tuft resorption of terminal phalanges, bony proliferation at base of phalanx with tapering proximal phalanx, which can be seen classically as pencil in cup appearance, asymmetric non-marginal syndesmophytes can be seen. Patients can also have asymmetric sacroiliitis. In diagnosing psoriatic arthritis, a particular criteria called Casper criteria is used, that is classification criteria for psoriatic arthritis. So this is done in patients with evidence of joint, spine or enthesial disease, and it includes 5 points. Patient is said to have psoriatic arthritis if the patient has more than or equal to 3 points from the following 5 points. The first is evidence of current arthritis along with presence of past history or ongoing psoriatic lesions, or the patient has a strong family history of psoriasis. Second is if the patient has typical psoriatic nail dystrophy on current physical examination. Patient should be negative for rheumatoid factor. Patient should have an ongoing dactylitis or a documented dactylitis in the past, which needs to be documented by a rheumatologist. And patient should have a radiographic evidence of juxta-articular new bone formation in hand or foot. So as mentioned above, any patient with 3 out of the 5 points is said to have psoriatic arthritis. The nail dystrophies usually described include onycholysis or pitting or hyperkeratosis. Once a diagnosis of psoriatic arthritis is established, how do we treat the patient? Firstly, a coordinated therapy is directed towards both skin and joints. Patient education, physical therapy, and occupational therapy are also performed. TNF modulatory agents such as certolizumab, infliximab, adalimumab, golimumab, and etanercept can improve the joint disease and delay radiographic progression. Out of this, certolizumab, infliximab, and etanercept can also be used in patients with skin disease. Osketimab, which is an anti-IL-12 and 23 antibody, also is effective against both skin and joint disease. Apremilast, which is a phosphodiesterase 4 inhibitor, also is effective in both skin as well as joint disease. Secukinumab and ixekizumab, which are both anti-IL-17 monoclonal antibodies, are found to improve the disease outcomes in psoriatic arthritis, and these can be used in patients with moderate to severe disease. Abatacept, which is a CTLA4 immunoglobulin complex, have been used to reduce the symptoms and in disease control of psoriatic arthritis. Other options include tofacitinib, which is a Janus kinase inhibitor, is used in patients with inadequate response to methotrexate or other disease modifying anti-rheumatoid drugs, which are not effective in such patients. Patients can also be treated with NSAIDs. Even intra-articular steroids can also be used in patients with severe oligoarthritis. Systemic steroids are, however, not recommended, as the patients can have rebound psoriasis or psoriatic skin lesions once the glucocorticoids are tapered and stopped. Sulfasalazine in the dosing of 2 to 3 grams per day is effective, but an important thing to note is that it is not effective in preventing joint erosions. Methotrexate is effective in dosing of 15 milligram per week, where it can improve the patient's symptoms and also affect the skin lesions. However, it is not shown to effectively improve the disease features. Patients with skin disease and joint disease can also be benefited by leflunomide. The next topic is enteropathic arthritis. This is the kind of arthritis which is usually associated with inflammatory bowel disease that includes both Crohn's as well as ulcerative colitis. And these arthritis can be both axial as well as peripheral arthritis. Arthritis can develop both before or after the development of inflammatory bowel disease in such patients. In patients with peripheral arthritis, they usually tend to have asymmetric and episodic arthritis, particularly involving ankle joint and knee joint. However, these arthritic episodes usually lasts for weeks and resolve completely without evidence of joint damage. Other features include enthesitis, Achilles tendinitis, plantar fasciitis, and if axial skeleton is involved, patients can have sacroiliitis also. Laboratory findings include an HLA B27 positivity in up to approximately 70% of the patients. They'll be classically negative for rheumatoid factor. Radiographs do not usually show any joint erosions or deformities, and in patients with axial involvement, this can always mimic ankylosing spondylitis with classical symmetric spondylitic lesions. In treatment of enteropathic arthritis, coordinated treatment for both joint as well as an underlying inflammatory bowel disease needs to be undertaken. TNF alpha inhibitors are known to improve disease outcomes. NSAIDs, however, can improve joint symptoms, but they can precipitate inflammatory bowel disease symptoms. Other agents that can be used in peripheral joint disease associated with enteropathy include sulfasalazine, azathioprine, and methotrexate.